The PA mobility test is performed to examine intervertebral mobility. Position the patient in prone with the lumbar spine in a neutral position. For some patients, a small pillow under the stomach may be needed to achieve this neutral position. First, the clinician follows the iliac crest to locate each PSIS. You should feel two small prominences lateral to the sacrum. Next, L5 is located by placing 3 fingers along the imaginary line between the PSIS and the lumbar spine. To confirm, the clinician pushes gently on the sacrum.
The most caudal location at which there is no movement is L5.
The clinician then positions his most caudal hand for mobility testing. The hypothenar eminence, or fifth metacarpal just distal to the pisiform, is positioned over the spinous process of L5. The clinician's elbows should be extended with the chest directly over the hands. The other hand is used for reinforcement and is placed over the first metacarpal of the mobile hand. The clinician creates a posterior to anterior force through the spinous process of L5 through their extended arms and wrists by leaning into the motion with their body weight. This creates a gentle but firm posterior to anterior translatory movement of L5. Upon reaching the limit of motion, note the end feel, the degree of mobility, and any provocation of pain. The clinician then palpates the next cranial bony prominence. This is L4. Repeat the PA glide for each segment and continue to move up the lumbar spine in this fashion until all lumbar vertebrae have been tested. A similar manual technique may be used to increase joint mobility if hypomobile segments are noted on testing. To increase general mobility, a grade 3 mobilization force is applied. Refer to the manual for dosage instructions. If a sustained hold is not tolerated, hold for shorter durations or apply oscillating mobilizations. To increase lumbar extension, the clinician can stand cranial to the hypomobile vertebra and apply the same grade 3 force. This changes the direction of force on the spinous process and produces a posterior, vertebral tipping, and posterior translation that occurs during lumbar extension. As a progression, the patient may also be positioned into further extension by going into a chin on hands position or prone on elbows position. To increase lumbar flexion, the clinician can stand caudally to the hypomobile vertebra. This changes the direction of force on the spinous process and produces an anterior vertebral tipping and anterior translation that occurs during lumbar flexion. As a progression, the patient can be placed into further flexion by placing pillows under the stomach.